So, joining me today on the Syra HealthTech Headlines podcast is Emily D'Agostino. She is a social epidemiologist. She's got a very wide, diverse background in this field. Thrilled to have you here today. Tell us a little bit about your background.
Absolutely. And thank you so much for having me on the podcast. So as you said, I'm Emily D'Agostino. I work at Duke University in the School of Medicine and the Duke Clinical Research Institute as a health equity expert. I mostly study community engaged epidemiology. So what that is I work together with community partners. All of my work is in the community settings. So that includes parks and recreation, faith-based organizations, schools, transportation, and so on and so forth. And I work on what drives health disparities, and I try to address them by reducing health disparities and health inequities in the population.
So important, and it's such a hot topic in the culture today. How does someone know if they're experiencing a health disparity?
Well, one of the things to remember about epidemiology is we work at the population level. And so we typically work in groups or populations. So we work with means or averages. So in general, we think about those populations that face health inequities. So typically we might ask about chronic disease disparities, for example. So cardiovascular disease or diabetes or cancer, obesity, who is experiencing these conditions and why? And a lot of the time, individuals will think about what they do. So what are their behaviors? What are the things that they do? Is it their fault? A social epidemiologist instead would think about those factors that are upstream. So what are the factors that reduce access to health? What are the factors that reduce opportunities for health? And what can we do at a population level to try to reduce some of those inequities and those disparities to try to promote health overall, particularly in these underserved populations that don't have the same access to health?
Okay, so you already answered the next question I had for you, which is what is the goal of all of this work? Is there progress that's being made from your perspective?
I think that's a great question. There is a lot of work being done right now around health inequities. There has been for a long time. The COVID epidemic and pandemic, I should say, brought a lot of light to not only very wide disparities in access to health, but some of the things that we need to do to counter those disparities. So in particular, a lot of research funding. So I mentioned that I'm at Duke. I conduct a lot of health equity trials related to trying to promote access to health for underserved populations. And a lot of funding now is being directed towards trying to understand what is driving those inequities, what has been driving those inequities, and why are those inequities widening. And so, yes, there's a lot of work being done, but unfortunately, health disparities are widening. We know, unfortunately, that just about 3% of healthcare spending is actually on public health. So while there is a lot of money being put towards trying to promote health, it is not necessarily directed at trying to reduce health inequities. So a lot of effort, a lot of interest right now in trying to understand what are those upstream factors that are driving in a lack of access to health and opportunity for health. And then what should we be doing about it to try to promote health, particularly, again, in those more vulnerable, those more underserved, under-resourced communities.
And why are these equity gaps widening? Do we have that intelligence at this time?
Yeah, so we certainly do have some of the intelligence, and I think we're continuing to learn. So we know, for example, that about 80% of what drives our health or health status is outside of what we might think of as sort of clinical care or clinical settings. It really has to do with, where we grew up, our access to education, our housing, what kind of social support did we have and do we currently have? What is our access to information? In what ways can we understand and use that information to promote our own health? Do we have access to green space or places to be active, to participate in recreation? Is that recreation safe? Is it easy to get to? Is transportation continuous, accessible, safe, affordable? And of course, we have to think about access to healthcare and utilization of healthcare. So what drives people to use health and opportunities for health? So we do know that those are the things, that umbrella tends to be what we call the social determinants of health. And that umbrella is driving these inequities. So yes, we know, but on the other hand, we have to dig deeper and we have to figure out, well, then how do we combat those inequities? And I think that's where a lot of the research is happening right now.
Oh, it's fascinating stuff. And you mentioned clinical trials that you're involved with. I'm a huge fan of clinical trials. I hadn't thought about them in the context of health equity. So can you give the listeners a couple of examples of what a clinical trial in this space involves?
Yeah, I would love to. So I mentioned that I work extensively with community organizations. One of the sectors that I'm very passionate about is parks and recreation. A lot of people don't know that parks and recreation or recreation centers are ubiquitous. They tend to be in almost every community. They tend to be accessible, affordable, and safe. And they offer opportunities for all aspects of health promotion, physical activity, mental health, social cohesion, programs, and many, many other things that I haven't just listed. And so one of the trials that I'm working on right now is related to trying to connect youth who may be experiencing stress and anxiety, particularly related to the effects of the COVID pandemic. We're trying to connect them to parks and recreation organizations and programs where they might attend and then benefit from those programs, and that may in turn help to alleviate some of their anxiety. There's a mental health crisis right now that's going on across the globe, particularly among youth, and so we're trying to reduce particularly health inequities related to these mental health challenges, and particularly anxiety for youth in underserved populations, thinking about how ubiquitous, accessible, affordable parks and recreation programs are. So that's one example of an intervention that we're working on, or a health equity trial. Another one we're doing is specific to trying to promote access to physical activity and green space, also with parks and recreation. So we have a program that is helping youth to use public and active transportation. So active transportation, walking, biking, using greenways, blueways, in order to both access places where they can be healthy. So for example, where to recreate with friends, where to, go to the public gardens, or, again, go to a program at their local parks and recreation facility, and how to navigate the transportation system, how to use, ride, be able to fix and maintain a bicycle, which again is not necessarily something that all children and all youth have access to. And so really thinking about what are those ways to promote physical activity. And again, this is a very upstream approach. So transportation is something that, the literature shows us that this is something that is absolutely accessible, affordable, is a way to promote youth to be more physically active, but we have to help improve what's called their transportation self-efficacy. So we have to try to increase their ability to navigate transportation systems and to do that in a safe way, and to help them advocate for changes that may need to occur in their community in order to promote safe, accessible use of active and public transportation. So those are just two examples where, again, working with a non-traditional partner, Parks and Recreation, to try to promote access to physical activity, access to transportation, access to better mental health. And that's just for the youth population. I work with all different age groups, but it's just two examples of, how we might promote health equity in this space by thinking about social determinants of health.
Such good examples. Thank you for those. And so, not to belabor the point too much, but if these youth are reached through the promotion of this opportunity, then are they able to visit the parks and recreation? Is that the part of the clinical trial they participate in? Use the transportation, and then that's studied over time?
Yeah. So, what you're pointing to, of course, what are the outcomes that we might measure in this kind of a trial, right? So, for example, the second one that I mentioned, the physical activity promotion, we are measuring their self-efficacy because we think that will help them, that transportation self-efficacy will help them to increase their ability to be more physically active through reaching parks and recreation, through actually participating in more physical activity. We're also measuring with accelerometry their actual physical activity. So they wear wristbands, with the equivalent of a Fitbit, and so we objectively measure what is their physical activity and what kind of physical activity are they getting. Is it moderate to vigorous? Youth unfortunately do not get the physical activity that they need. The Centers for Disease Control says that youth up to age 18 should get 60 minutes of moderate to vigorous physical activity every single day. And about 3 out of 4 kids do not get that physical activity. They're not meeting those guidelines. And the disparities are even worse, as we've been talking about, among underserved populations. So we measure their physical activity. We also measure their step counts in addition to what level of physical activity they're getting. And we measure various things that have to do with the program itself to make sure that the intervention is doing what we think it's doing. So there are a lot of different ways that we take surveys or we collect survey data to try to understand, what may be driving the change. We ask a lot of questions around their environment and their behaviors, as well as their sociodemographics. So some of the data is survey-based, some of it is accelerometer-based. We're also trying to measure their cardiometabolic health. So we collect their blood pressure. So there are a lot of different ways that we try to collect data. And then lastly, we have focus groups. And so again, we're trying to generate some qualitative data to understand, what's driving the inequity. Is this having an impact? If so, why, how, and so on and so forth. So a lot of data collection, and again, a lot of ways to try to say, is this working or not? The goal is to essentially, with this trial, say, okay, if it's working, if we're able to show that it's working, the next step would be to translate it elsewhere. So what are some other communities where children might benefit from this? And then how do we expand? How do we translate it to these other settings? And, provide access to more youth and prove that it not only works in this one setting where we're offering it, but other settings. So again, sort of that's kind of the cycle of what we do in this sphere in health equity trials.
So exciting. I love the thought of all these insights being spread across the country. And anyone who might be interested that may not have known until hearing you today that you can participate in a health equity clinical trial, are they available on clinicaltrials.gov? Is that where folks can look for them?
They sure are.
Wonderful.
Yes.
Wonderful.
Yes, they definitely are.
So just to wrap things up, I like to envision a world where health is equitable. What are some ways we know we've achieved that, or what can that potentially look like?
A great question. I think you're asking a data person as an epidemiologist. So I always think about data, and a lot of people think that data is only for the scientists, and actually a lot of data, more and more, is becoming public, and there are ways to find maps where you can look at, for example, what is the prevalence or how common is heart disease? And then you can zoom in to particular areas and see, are there differences by geographic region? Or you can click on, for example, various socio-demographic factors. Are there differences according to race and ethnicity, or poverty status, or education? or the age of the population, those who may have, limited English proficiency. These are all things that a lot of these sites you can hone in on. And ideally, if we've achieved equity, what you'll find is it doesn't matter what you click on, you don't see a difference. You don't see a pattern. Now, of course, that's very optimistic. And I think what we're looking for is to not see that pattern. But because there is a pattern, that helps us to essentially try to solve, where is the problem? What do we need to do to fix it? What are the layers that we need to unpeel to try to understand and then better address these disparities?
Sounds so good. And a day to really look forward to, a day, as you say, where there's no patterns and we're all treated equally. And in this case, from a health perspective. It's been so good to hear from you today, to learn from you today. Thank you so much to Emily D'Agostino for joining us. We appreciate your time and wish you all the best.
Thank you so much again for having me.